evening, everyone. I am Dr. Richard Ferguson. If you may not know about me, founder, president of BPOU, and I'm pleased to welcome you to our Men's Health in the Black Community. Tonight will be a presentation and also, I think, a bit of a conversation. It's especially important because Black men continue to experience disproportionate burdens from hypertension, cardiovascular disease, prostate cancer, and other preventable and treatable conditions. Black men are more likely to develop prostate cancer than other men, and more than twice as likely to die from it. And our presenters here, particularly Dr. Langston and Tyler Thompson, will be providing some education and tips and more insight in how preventative care can be more, done in a more qualified manner, the importance of early screening, and how you can have conversations with your loved ones that may have hesitation about seeking care. But before I go further, I would like to first do a little brief introduction. So we have Dr. Devon Langston. He's a urology resident, I believe chief resident, right, Dr. Langston?
You got it. Finally made it to the finish line.
At University of Utah Health, his clinical research interests includes men's health, infertility, sexual function, and cancer survivorship, and disparities in urologic care. We're also pleased to welcome Tyler Thompson. He is a senior, or going into his senior year at University of Utah. He's studying biology and French. He plans to attend medical school, hopefully within the next 48 months. He is also one of our 2025 clinical research scholars and a soon-to-be MCAT Pred scholar. So please join me in welcoming Dr. Langston and Tyler Thompson. And I will hand it over to you. Oh, a little bit of housekeeping. There will be points in the presentation where you can ask questions, but there will be small quizzes or questions that can occur that will allow you to be able to get an Amazon gift card. The final answer will be decided by Dr. Langston or Dr. Thompson on who's first. We will often ask you to put your answer and your email in the chat. It's kind of like who gets it first, and then whoever has the correct answer first is what's most important. You can only win once. Okay, this is not someone. So if you happen to be a urology first year, this is not your time to shine and take all the Amazon gift cards. You get one opportunity. Same thing for a fourth year medical student. Same thing. You get one opportunity. There will be several chances, and it's important to include your email because you will get it in a few days or so, a day or so after the presentation. So without further ado, I'll hand it over to you, Dr. Langston, or whoever's going first.
I believe I'm going to start out a little bit.
Okay, all right.
Add in here and there when I go through like more of my chronic conditions as well as oncological.
Excellent.
As well.
Can everybody see the screen okay? I'm sorry, Tyler.
Yes. And everyone can hear me okay?
Yep.
Perfect.
All right, awesome. Take it away.
And if there's any questions along the way, you guys can raise your hand into the comment section or add a comment. Hopefully I can see it, and then we can keep going forward. But welcome to our conversation about men's health in the Black community. Again, I'm here with Dr. Langston and myself, Tyler Moses Thompson. Sorry. So July is a month for many months. July is for 4th of July as well. If you're from Utah, July could also be for Pioneer Day. But today we're going to celebrate July for Black Men's Health Month. It is a month to celebrate Black men's health gains and improvements. It's also time to reflect and adjust on worrisome habits, and also learn about maybe some other concerns that could come up in the future, and also learn about risks and concerns that may affect you, a loved one, or anyone within the Black community. Also, there's Frozone. So the contents of today's webinar, we're going to talk about different health demographics and medical census and statistics for Black men. And once we're done with that, we're going to talk about different crucial diseases and concerns affecting Black men and different oncological diseases as well, where Dr. Langston's going to take over. And then we're going to talk about mental health and stigmas associated with Black men's health. And then we're going to wrap it all up with preventative care and societal change, just for like a good wrap up and seeing where we can go forward from here. So here's a large view of Black men's health. We're going to get to this graph in just a second, but I'm just going to roll through some statistics beforehand. Within the US, there's about 20 million Black men in the US, which is just shy of 6% of the national population. And in Utah, that number dwindles even more, with 67% of Utahns identifying as Black themselves. Black men's life expectancy is significantly lower than the US citizens' life expectancy average, being only 70 to 72 years of age. And a US citizen's life expectancy is around 79. This is due to many medical and non-medical factors, which I hope to talk about today. But this kind of translates us to this graph where we see three other demographics as well as Black men. And Black men is that low red line at the very bottom. This spans from 1970 to 2012 or the present day. And you can see that in 1970, it was about 60 years of age and almost parallel with the other trend line graphs. We reached that 70 to 72 age that I was mentioning. For Black women, it's more on line with the white men trend line, and that's that purple marker, I believe. And then white women are at the top of the chain with averaging around 80 years for their life expectancy. And some more statistics before we keep going. We're talking about more healthcare and coverage and different inequities with healthcare coverage. So on average, we see, and also before I keep going, this whole slide is from statistics from 2017, so expect like a couple percentage variables. But what we see in 2017 that 90% of Black Americans had healthcare coverage, compared to 94% of white Americans. And about half of those people that do have healthcare coverage, they're actually government-based healthcare coverage, which is a little bit different than private. It's just a different level of umbrella. More general is the government health issued coverage, and more private could be more niche towards your needs. And then that last bullet point, the 12.1% of Black Americans under the age of 65, just reiterate that top point in that red point marker. And this slide shows the same exact thing from that bottom bullet point, but it just shows a lot more demographics within America. Surprising or not, sorry, I need to move this little thing. Surprising or not, African Americans do not fall. We fall in the middle pile with people insured in the U.S. There are three other demographics that are they find worse percentages of insured of people not insured. That is the Asian community. That is also the Native American community as well as the Pacific Islander community. We fall within that 10.1%, which is that purple trend line going down. But with all of these trend lines, what we see is they're all going towards that 0% point, which is what we want. We want everyone insured. We want everyone to be able to have the health insurance that they need and feel the need, and they feel the will to be able to reach their optimal health outcome. All right. So for you now is the 10 major challenges to Black men's health. They are in order. Number one is heart disease. And if you know anything about BPOU or Dr. Ferguson, he promotes heart health. And heart disease is definitely a crucial factor affecting the Black community. It is number one. Hypertension is the main reason causing heart disease. It's kind of the consequence of hypertension. Then we're going to talk a little bit more about cancer as well. The three cancers that we're mainly looking at in regards to Black men is prostate cancer, colorectal cancer, and lung cancer. And then we're going to talk about homicide. Homicide is a big factor challenging Black men's health. I'll get to a little bit more statistics about that later, but until we can treat violence in the Black community, we cannot be considered a healthy community entirely. Next, we're also going to talk about the diseases of the respiratory tract. We're also going to talk about diabetes, especially diabetes type 2, kidney disease, HIV, septicemia, which is actually a consequence mostly found from pneumonia. And pneumonia is right there in spot number 9. And then unintentional injury comes at number 10. All right. So now we're going to face or look more at the chronic diseases that are mainly affecting Black men. And all these fall within the top 5 of that list I just showed you. Heart disease, of course, being number 1, derives from hypertension, which is just high blood pressure. And stroke is the ultimate result from that. Stroke has a much more fatalic rate, and we don't even want to reach that point. So if we keep aware of our our hypertension and our high blood pressure, we need to make sure we aim for that 120/80 of diastolic and systolic pressure. Then we can work on focusing a little bit less on, we can focus more on our heart health. Another chronic disease that we need to face is diabetes as well, especially type 2, where insulin isn't working properly. We need to get insulin from an outside source. Diabetes is kind of a consequence to a little bit unhealthy lifestyle, a little bit unhealthy eating habits, and a little bit unhealthy exercise habits, but it can also be a consequence of obesity as well. So for our preventative care and management for these for these chronic conditions, it's going to be pretty repetitive to some other slides that I have, but I need to make sure that we have this fully understood, that it is the same kind of steps. First, we need to understand that routine screenings are crucial. We need to monitor that blood pressure, that 120/80 of diastolic and systolic pressure. We also need to manage our cholesterol. And also for diabetes, we need to be able to screen our blood sugar as well. Um, and it's good to have good primary care relations with your provider because they're able to tell what range that you're supposed to be looking at. Because 120/80 is a very general kind of diastolic and systolic pressure, so it could be more variable towards you. We also need to be able to adjust our dietary in what we eat and what we consume. So fruits, vegetables, and whole grains and lean proteins are what our body needs and what our body wants. And reduce added sugars, especially for diabetics. And then physical activity is essential for us to maintain bodily function and just make sure that we are healthy as well. So on average, for a week, we need to aim for 2.5 hours or 150 minutes, which is less or more than some people may think. However, it's just to cause a healthy habit. And those healthy habits can later proliferate into more hours spent for physical activity. And that's just better for heart health and for body management. And now we're talking about erectile dysfunction, so I'm going to pass it over to Dr. Langston.
All right. Thanks so much for allowing me to participate in this talk today. But one additional marker of overall health is erectile dysfunction. And there's a lot of stigma around erectile dysfunction. However, it's a common physiological and physical and highly treatable vascular condition. And how we define it is the persistent inability to maintain an erection for satisfactory performance. And to receive this diagnosis, you have to have this happening for at least a few months. Most people say about 3 months is the cutoff. But really, and perhaps more importantly, erectile dysfunction is a physical health condition, not necessarily a personal or moral failure. And the condition does correlate with age. And so 40% of Black men over the age of 40 are often coming to the provider with concern for erectile dysfunction, and 70% of men in their 70s are having the same complaint. You can click to the next slide. So one of the things about erectile dysfunction is that it can be a sign of cardiovascular issues. So I like to think about it when I'm talking to patients as sort of a check engine light for other cardiovascular issues that may be going on. So to understand this, you first have to understand how the heart plays a role. So coronary or heart arteries are these very large vessels. However, when these large vessels are unhealthy, they get plaque that builds up in these vessels. And when these plaques build up in large vessels, they ultimately impact the smaller vessels downstream. Unsurprisingly, the penile arteries are very small and they can be affected by the plaque in the larger arteries. When this happens, this is what ultimately can promote as erectile dysfunction. ED often, or erectile dysfunction, often act as a warning sign for other conditions, specifically cardiovascular issues, and it can be a sign 2 to 5 years before a heart attack or even a stroke. So men in their 40s with erectile dysfunction have an 80% higher risk of heart issues within 10 years of having a diagnosis of erectile dysfunction. So what about diabetes and high blood pressure, as we've been talking about already? So high blood pressure damages the lining of those small vessels, which also results in restriction of flow. And type 2 diabetes damages both the blood vessels and the nerve needed for erections, leading to a loss of function and sensation. And in fact, approximately 66% of diabetic men experience erectile dysfunction, and ED or erectile dysfunction is often the first visible symptom of undiagnosed diabetes or hypertension. So, what can you do? Lifestyle modifications such as regular exercise and weight loss, as Tyler has already talked about. Medications, which you can talk to your primary care provider or your family medicine provider to get you started on, such as Viagra and Cialis. And it's important to note that common side effects of these medications are headache and facial flushing. Men who use these medications actually have a 40% lower rate of cardiovascular issues, specifically death related to a heart attack or stroke. More advanced therapies are available, but you should talk to your provider to get them hooked up with a urologist to be able to talk to you about these therapists. And what should you do? So, step one, schedule a primary care checkup to assess vital cardiovascular numbers such as your heart rate. And explicitly discuss any erectile changes with the primary care doctor so that way they can get you hooked up with a urologist. And this picture on the last slide or in this slide is actually of many urologists who are currently residents at institutions all across the country who will be graduating in the next couple years out in the workforce to help you with these needs.
I have a question.
Yeah.
All right. Now, lately, at least from what I've read over the last couple years, and even that I've used in some of my medical missions abroad, is there now kind of like a dual use for medications such as Viagra and Cialis, especially when it comes to disorders of the prostate, and they also have erectile dysfunction. Is there sometimes a dual benefit now?
Yeah, especially with Cialis. It's the first FDA and actually I think the only FDA approved drug that actually takes care of both. And so you can get started just on a daily small dose of Cialis, and it's nice because it treats both, as you said, erectile dysfunction and those who have issues with voiding or peeing because they have an enlarged prostate. So you kind of get, instead of two medicines to treat two separate things, you get one medicine that treats both. It reduces the number of pills you have to take. And also, a lot of men are very happy because you get restoring and good peeing and also good erection.
Thank you. So I guess that's something that when you're going to your next appointment to maybe consider, hey, you got a little something that can help me with both. But it's something that I have noticed more on medical reconciliation lists lately. Anyhow, I will stop. You guys are getting to the good part.
And that good part is our gift card giveaway question. We'll be giving out a $15 Amazon gift card, like Dr. Ferguson said. Dr. Ferguson, I don't know if you want to say the rules again about how it's going to work.
Yeah, so you will give the question, and whoever's first to answer, and then you guys decide who has the correct answer first. And then once you decide, that person needs to add their email into the chat.
Easy enough. All right, make sure to type in your responses after I say the full question, please. Just make sure it's even. All right. So how many Black Americans have health insurance, to keep it simple? A, B, C, or D? And Dr. Ferguson, I'll have access to the chat, or can I?
You should. You should. Your co-host.
Jennifer Charles is
I see.
hot on with the first response.
Oh yeah, quick.
Very good. Very good.
Yes, Jennifer, you are correct. It is B, 89.4%, just shy of 9 and 10 Black Americans have health insurance. But these other numbers that I have up here, and sorry, Jennifer, make sure you send your email, correct, Dr. Ferguson?
Yes.
Okay, send your email into the chat as well. But some of these other numbers that I have up here, 44.1%, if we remember, is the amount of Black Americans on government health insurance. And then this 93.7% is the amount of white people on that have health insurance. And then 16% is just my favorite number. So that doesn't mean anything. And also, before we go on to the next slide, let's all say rest in peace to Chadwick Boseman, because we have to talk about oncological diseases. And the three that we're mainly talking about is prostate cancer, colorectal cancer, and lung cancer. Prostate cancer, I'm gonna leave more for Dr. Langston, but it still is a but we still need to know that diagnosis mortality rates for prostate and colorectal cancer are very high amongst the Black population. And this is mostly due to later stage diagnosis. And this kind of goes into systemic and health inequity kind of portion that we're not able to have early screenings and early access into these hospitals with uh, that are able to screen for these diagnoses as well. So when we finally get into into those hospitals and get diagnosed, it's normally later stage and it's kind of harder to treat those cancers. So prostate cancer and colorectal cancer, we see those very often. And then lung cancer, simply enough, smoking remains the primary risk. But when I was doing research for this presentation, I found out that with lung cancer diagnosis, about 20% actually do not smoke at all, and it actually comes from secondhand smoking. So what I'm trying to preface is that it all depends on if you're if you're breathing in clean air, and make sure that you're not around that bad air for too long. Here are some more statistics about cancer rates within the Black community. I'm just going to give a kind of quick summary of this, but this is from the American Cancer Society in 2025. The two boxes on to the left kind of just talk about how Black people have a lower 5-year cancer survival and a higher mortality rate than their white counterparts. But this is also due to that late stage diagnosis that I was mentioning, and the more of those systemic issues. What I really want to focus on is that Black men have the largest decline in cancer mortality on the right side. This is simply due to, I believe, more representation within medicine. As we see more representation within medicine, we also see better healthcare outcomes as well. For this example, cancer. And we'll see that trend a long way. And that's the whole reason for BPOU as well. As we get more representation, we also get a more decline in mortality rates. So the preventative care and management for these oncological diseases are cancer screening options with healthcare providers and establishing a good provider-patient relationship. For screening, it depends on the cancer. It also depends on your family history as well as other factors as well. But we want to start screening between ages of 21 and 45. Once again, this is very variable. So as I am 21, I should start looking into cancer screening, but probably depends on certain factors. We also need to have a healthy lifestyle. Once again, this is going to come up multiple times in this presentation. We need to have regular exercise and a balanced diet. But most importantly, for colorectal cancer, we need to have a high fiber diet and low processed meat intake. That's why I have this graphic in the corner that talks about high fiber foods. So please take a look at that. My favorite high fiber food is fig Newtons. I love fig Newtons and fig in general. So that's my recommendation. Also, we need to avoid smoking, especially for lung cancer. But for all cancers, especially, we need to avoid smoking and excessive alcohol consumption. Both of those make the body weak, and if the body is weak, it cannot properly function, and it cannot fight off those ailments. Now on to prostate cancer with Dr. Langston.
So I think the easiest way to understand prostate cancer is just to first start with the basics about what is a prostate and why does it exist. So to answer a question of what is the prostate's a very small, it's about 20 to 30 grams or the size of a walnut, organ that lives, kind of sits down below the bladder. I think you have to click the next slide for me there, Tiger. That's just beneath the bladder, as you can see in the picture there. And the primary role that it has is actually in reproduction. So it produces a protein that tells semen to become a liquid, and that's why it comes out as a liquid. And that liquid actually protects and carries sperm forward for reproduction. And then the urethra, or the urinary tube, runs directly through the middle of the prostate, as you can see in the picture. And as we already talked about before, naturally, a free gift, I always tell patients, a free gift with being born male is that as you age and grow, your prostate too will age and grow. And that's just a natural process, and we call it BPH, or benign prostatic hypertrophy. So what do we know about prostate cancer and how it relates to Black men? We know that prostate cancer is actually the most common cancer diagnosed in Black men. We know that prostate cancer, Black men are approximately twice as likely to die from prostate cancer. we know that there's about 44% to 75% higher chance of being diagnosed with an advanced disease or more aggressive form of prostate cancer for Black men. And early detection is the most effective way to prevent, men from being diagnosed with a more aggressive form of prostate cancer on presentation. So more on how it's different in Black men. Prostate cancer develops 3 to 9 years earlier in Black men compared to all other racial groups. The baseline screening is recommended to start at age 40 for high-risk men, which Black men fall into that high-risk group. Screening is simple, it's not invasive, it's a blood test, and it's looking for something called PSA, which we say is prostate-specific antigen. However, only about 30% of primary care doctors routinely check a PSA, especially at around age 40 for high-risk men, which again includes men of Black ancestry. The physical exam component is why I think most men choose to not get worked up for prostate cancer, because it does involve a digital rectal exam. But you should know that this is optional and it's not required in order to get screened for prostate cancer. So what to do if you have it? So what they'll do is they'll check your PSA and they'll let you know if it's normal or abnormal. If it's abnormal, they'll say it's elevated. And if that happens, we typically recommend you get imaging, which these days is most commonly an MRI. And then with that information, you and your provider can decide whether or not you should get a biopsy. Many prostate cancers grow slowly and they never cause harm or symptoms. And so the common theme for prostate cancer is that you're more likely to die with it than of it. And it's more likely to be something that, once you get diagnosed, that we can treat you with different groups. The main common ways we treat it is we can put patients on something called active surveillance, which essentially is you get a set number of appointments with a provider, you come back with additional imaging, so it can be another MRI, you get more PSAs, and then also they'll decide again whether or not you need a biopsy. We can perform surgery. As urologists, we are surgeons, and so we can remove the prostate from the body. And then if surgery is not the appropriate option for you, or if that's not your preferred option, we do have radiation therapy available. And active surveillance is usually what most guys go on, and means that we closely monitor you with blood tests and scans, and it safely avoids all of the negative side effects that can come immediately from surgery or radiation. So that's why most men end up on active surveillance. So what can you do? First thing first, you can ask male relatives about any family history of prostate issues and specifically focusing on prostate cancer. You can mark your calendars for a baseline PSA screening discussion at around 40 to 45. You can engage in shared decision making with your doctor to see if PSA screening is an appropriate thing for you. And you can share information you learn from today with other men in the community to help inform them about getting their screening done starting at age 40 to 45.
All right. Thank you, Dr. Langston. Now we're going to switch focus a little bit. We're going to talk more about the systemic factors to health inequity, what drives these inequalities. And I have this picture up showing a domino effect. And simply put, it simply is just a domino effect. It's a historical domino effect that has brought us to our present day. And I'd love to illustrate that for you guys now. So looking into our community, we have some pervasive issues that we need to reflect on. Poverty is a big thing within our community, of course, and that's one tipping of the domino. Poverty is just the start. Poverty can lead to improper housing, can also lead to improper access to healthcare, can also lead to violence, which we're about to talk about right now. So roughly in violence and homicide, we see about 11,000 Black men die each year in the US due to violence. And like I said before, violence in any community detriments that community, and it doesn't make it necessarily healthy. So we need to address this some way or another. Police shooting as well. We need to understand that this is a harm to us as well. U.S. police fatally shoot an average of 300 Black individuals annually. And without demographics involved at all, about 12,000 there are 12,000 fatal police shootings recorded every single year. This one was just 2025, which was 1,138. This is very consistent, but also most of these fatal police shootings are marginalized and non-representative people. So just good to be aware about that. And this also brings us into our mental health idea. with all these different pervasive issues, with all this trauma that Black people have been facing, there is a more of a need for mental health treatment and mental health need. However, as we see more people needing to seek mental health, we actually have less people showing up in the Black community. About 25% of Black people seek mental health treatment when needed, compared to 40% of white people. This could due to the same thing that I talked about earlier with the cancer diagnosis, that representation is low within the psychological workforce. About 3% of psychological workforce is that in the US is Black. So with less people being able to represent or be able to understand maybe a situation, especially in mental health fields where mental health is very personal, it could be a factor why a lot of Black people are not seeking mental health treatment that they need. And also, I have down here that racism has been declared by the CDC as a serious threat to public health, and public health also entails mental health. So we should not denote that racism does impact mental health, even though some people may say it is not. Some more awareness for Black men about mental health. We have a higher rate of PTSD, 8.7%, and I believe white men is about 7.4%. And this could be to many reasons, violence within our communities, also trauma, like racial trauma, has always been prevalent. And if anyone will tell you about trauma, trauma is in a linear progression, especially in the generational way. The Your father's trauma obviously comes down onto you because of his worry. And this is a generation to generation thing. Um, we can see this obviously with slavery, only 4 generations apart. And unlike people like to say, slavery is not that far away from the present. So this trauma and oppression holds significant weight of the descendants, and sadly, we are those descendants as well. So that trauma and oppression is holding with us, and we need to talk, and we probably need to seek out mental health experts and mental health awareness as well. Now going on to more stigmas of mental health and also stigmas of general healthcare. But before I go into this, I want to make sure to get this clear, is I'm not trying to cause any worrisome feelings about stigmas in our healthcare system. I'm more just trying to make people aware and also understand that there has been a consequence to these stigmas as well, that there have been changes within our government and within our bureaucratic system. But that goal that I want to make sure that everyone understands is that accepting that mental health concerns and disorders are something treatable and not something to be ashamed of, rather. Now, going into some of these stigmas of mental health, one of those stigmas is obviously representation. There's been lack of representation within the mental health sphere, not having a lot of Black people being able to put in their opinion. And also, mainstream psychotherapy has its roots in Western Europe. So the institutions, the founders, and treatments were for white men and women, not rather non-represented people or marginalized people. And for historical count, more for general healthcare, the U.S. advancement in medicine surgery completely and utterly derives from slavery. The U.S. is especially has advanced in surgery, and this is because there's been many years of practice, to be frank, with people that were considered property. But before I go any deeper with any stigmas, I want to take the time to talk about the Mental Wellness Alliance. They know more about mental health than I ever do. What I'm trying to just say is just a little summary about some of the stigmas of mental health, but these guys completely understand it full on and full through. This is their profession. They are professionals in mental health, and professionals with mental health in the Black community. They have a few events upcoming that I'll talk about at the very end, but I'm just trying to let you guys know about this. So with more mistrust in the medical system, there are plenty of historical examples. I have 2 for you guys today. One of them is the Tuskegee syphilis experiment. This is that depiction of on the left, which primarily affected Black men in Alabama, in the small town of Tuskegee, right outside of Auburn, Alabama, if you're aware of that. So the Tuskegee syphilis experiment, the whole idea of it was that they added a live strand and they tested on Black men, adding a live strand of syphilis into Black men and just practically seeing what happens. This was going on for decades, and most of the time when you look up the Tuskegee syphilis experiment, you see that it's in black and white. However, that's kind of just to throw us off course. There are colorful pictures like I brought to you guys today. And it actually ended in 1972. And the backlash for it is still being felt today, or should be felt today. Another example that I have of different mistrust within the medical systems is Henrietta Lacks, the story of the HeLa cell. And as I work at Huntsman Cancer Institute, and I'm a undergraduate researcher, I study acute myeloid leukemia and mantle cell lymphoma. I am in contact with many cancer cells. And the first cancer cell that we could actually use and utilize in medicine was HeLa. And this was taken from a Black woman while she was being seen at Johns Hopkins. It was taken against her will, without her consent. And after she died, the family didn't know about it, that Henrietta Lacks was still practically alive within these cells, being used in all these cancer facilities around the globe. And they're still trying to find justice for it today. So I highly recommend you looking into both of these historical examples and have your own conclusions about them. And I cannot overiterate that U.S. advancement of medicine and surgery completely derives from Black men and women, as we see here and as we've seen throughout slavery. And so from the backlash of all this new reports coming out about the Tuskegee syphilis experiment and Henrietta Lacks and the multiple other examples, there had to be critical pivots to medicine. One of those pivots was stronger research ethics, especially following the Tuskegee syphilis experiment. And then there was a federal requirement to make informed consent a thing, as well as the Health Insurance Portability and Accountability Act, which is HIPAA. That was enacted in 1996, and that's just a way to be able to for a patient to have more control of who knows about their healthcare status, healthcare information, and they get to choose who gets to know and who does not. I have one last book recommendation. This is a book called Medical Bondage. It's a little bit away from Black men's health a little bit, but it still talks about how the healthcare system in the U.S. was completely off the backs of Black Americans. But gynecology is another advancement in U.S. medicine. And this happened during the time of slavery when all these advancements happened. There was a lot of people that were considered property that could be treated and exploited about. And we have to keep in mind that this horrific history lasted 3 centuries. 3 centuries in America, but 4 centuries on this continent. So we cannot understate that enough. And so this brings me back to that domino effect a little bit, that 40 acres and a mule, aka reparations. This is, I believe, the tipping point of that domino effect. It's the one that pushes poverty down and pushes violence down and then pushes down improper housing and then improper medical outcomes as well. I have a little spiel about how the 40 acres and a mule saying came to be, but ultimately it was Black leaders emphasizing that land ownership was essential for true freedom and economic independence. But we all know the end of this story, that none of those were met. And this kind of steps off that domino chain where poverty strikes in, and then there's no foundation to go on any farther. So ultimately, the big picture that I was trying to show for you guys today was that the Black community's health inequity derives from the nation's domino effect. And this domino effect has led to many other systematic inequalities. But ultimately, I want to talk about how it affects Black men's life expectancy. It makes Black men's life expectancy lower than any other demographic. So for a preventative care summary, to wrap this all up, there are some things that we as ourselves can start tomorrow personally. And there's some things that that we can make a coalition for, more unification and more legislative action towards, which is our systemic and health inequity issues, what I just kind of mentioned. And if we're handling our systemic and health inequity issues, we could also handle our mental health and historical stigmas by combating those at the same time. More for our personal things that we can handle on our own, maybe starting tomorrow, hopefully, is more preventative screenings, being in contact with our primary care physician and having consistent checkups with them. We also need to make sure that we have a lifestyle change, diet, exercise, and change of socioeconomic conditions. That's absolutely necessary for us to pursue forward. And now we have reached our gift card giveaway question, our second one. Same rules apply. Make sure I read the full question before you guys answer, please. Let me bring up that chat section to make sure I can see it too. Oh, there it is. What is the ratio of Black Americans who seek mental health treatment versus Black therapists in the US? So this is a ratio. It's a little bit tougher of a question.
Great stat too, by the way. I think it's something that should be shared more in our forums.
All
Right,
right.
Jerome?
And since I see no more questions or answers going in, I believe the first one correct was Khadijah. It is D. 25% seek treatment, and there's only 3% of Black therapists within the US. Obviously, I'm trying to reiterate that there's less amount of representation within the Black community compared to other communities in the US. And obviously, more than 25% of people need to be seeking treatment. Especially these are people that are desperately needing that treatment. All right. So what can we do tomorrow? This is another wrap up. A little bit, we can change our unhealthy habits to healthier alternatives. I'm going to preface that 2.5 hours of exercise per week, and we need to take notice of our diet. But ultimately, we need to make both of these fun because it sounds more like a chore when I keep bringing it up and up. But if we can make exercising fun, like for example, my father loves to just wake up at 6 a.m. in the morning and go golfing for some reason, and then come back home and just rest. But that's a great way of exercising per week. And now he's starting to build on that habit of doing 5Ks and going out on more nightly strolls, which is great. We can also have a consistent relationship with our healthcare provider. Having that patient provider relationship is essential, and it just helps us grow as two people working on the same problem. We can also stay up to date on governmental proceedings. This is more for our systemic factors. We can reach out to local representatives and community leaders for better ways to proceed, better ways to fight the good fight. And this fourth bullet point is more for me. I believe that everyone should seek out knowledge on their own and especially should read. Um, there's a lot of people now in the world that are saying that this is the right way, this is what is correct, this is the historical correct way. But seek out your own knowledge, find conflicting views, and knowledge is power by the end of the day. Another way to find that 2.5 hours in a week for exercise is BPOU's BSTR, Brothers and Sisters That Run. They do hiking, running, cycling, swimming, and water training. I had the opportunity of being a captain for them last year in the summer, and it was a great time. It was a great time working with the community and promoting heart health. So I highly recommend. I'm pretty sure they still are coming out with events, and more info about that will be on the BPOU newsletter as well as the website. And bringing back to the Mental Wellness Alliance, here are some of their upcoming events. I did not know that there was an event today at the Marmalade Library. Then there's also going to be a Black Women's Forum tomorrow as well. And then there's going to be another Black Men's Mental Health Forum at the very end of this week. So if you have any questions, anything that I couldn't describe or explain correctly, these are the people to talk to about mental health. And ultimately, thank you guys very much, and we'll leave the rest of the time for questions.
Deja.
Can you guys hear me?
Yes.
Okay, first of all, I want to say great job, Tyler. That was an amazing presentation. I'm very proud of you. Sorry, I'm outside. Second question, the question I have is, how do we encourage the men around us? There's a lot of like stigma to like culture and religious beliefs due to like, how do we encourage them to go and seek like mental health, like help,
It's kind of hard
and
to
like fight that stigma?
100%. It's kind of hard to encourage that. Sometimes it's more just exposure, being able to give insight, like you can give more information, you can talk about it a little bit more. Statistics help. I always recommend providing knowledge, giving reading, let them read and be able to come up with their own choices at the end of the day because it is their choice to go find that therapist. So it's kind of hard to combat on our own. Um, but it just takes time, it just takes effort, and I believe if you come out of love, it should work.
Thank you.
Thank you, Khadijah.
I want to say great job there, Tyler. And I also want to give a big thanks to Dr. Langston. I know you guys have worked long and hard on bringing this presentation together. I particularly want to emphasize that BPOU regularly has engagements like this on a pretty much monthly basis. We will probably, our next is going to be a little bit more specific to providers, particularly on how to handle and avoid malpractice. So that will probably come up at the end of August, early September. But probably starting at in the beginning of September, we will have our next webinar because we're pretty busy with our back to school mental health and a couple of other events in August. But yeah, are there any other questions? I think this was great. I think one thing I'd like to point out to people is how the criteria for what is considered stage 1 hypertension has changed. And due to the JNCC guidelines from, this is probably now 7 years ago that it changed. So there's many more people now that actually will fall into being considered hypertensive. And I always try to go with an easy stat. Pretty much if you are African American and you are over the age of 40, you're 50% chance that you are hypertensive. Either you don't know it yet and you haven't been regularly screened, or and then even fewer of those 50% are actually getting treated. And so one thing you definitely want to do is to get screened, get on the medication if you can, or change with lifestyle management, as Tyler had alluded to. So Khadijah, do you have another question, or was that? And feel free, anyone, to place a question in the chat.
I do have another question.
Yeah.
How do we implement young Black boys into like receiving mental health so they're more comfortable with like seeking out for it earlier, like as they grow older?
I believe that there's not been a lot of discussion because I am a young Black man. There has not been a lot of discussion about mental health growing up at all. So I feel like if we start the discussion early, especially around like family, and if family members can all talk about it together, that's the first way to combat it. And then in other realms as well, we just need to consistently bring up the topic. And the more we bring it up, the more people will ask questions, especially our young men who are still learning about life. And they'll find a way to reach that treatment.
Okay, thank you.
And I wanted to make sure that when Tyler had mentioned about the importance of making sure you're able to do some research and ask questions, one of the things that I want many people to kind of understand is there are reputable resources. There's a lot of misinformation there. Actually, they're numerous compared to though that is reliable and evidence-based. We at BPOU believe in science, especially anything that can be verified and repeated. And so I will be slowly dropping into the chat here some of the sources that we use when we're producing our content. And much of that is either Johns Hopkins, Mayo Clinic, American Academy of Pediatrics, American Academy of Internal Medicine. So some of our large professional societies, also for urology as well. But one thing that we want to make sure is that you know where to look, as opposed to someone that has a loud voice and opinion online and may not steer you the right way. And Dr. Langston, any closing points?
I think most importantly, just talk about prostate cancer with your family because it's surprising how many people just don't know. and there are a lot of people in their family who may have it, who may just not have shared that with you, and just having that increased risk that's like the number one risk factor is A, having Black ancestry, and then number two, having a first degree relative. So if your dad, your brothers, your grandfather have it, then that increases your risk even more. So I think having that conversation with families is extremely critical to helping reduce Black men showing up with more aggressive prostate cancer on their first visit with us.
And speaking of that, Dr. Langston, there is a question for you here in the chat. I don't know if you're able to see that there. Is there a time frame when you would transition from surveillance to surgery, radiation? It's complicated there, so that's a shared decision making.
Yes, that is very nuanced and complicated. Um, but typically that's usually done when, if you're developing symptoms or if you as the patient say, hey, I want to transition from surveillance to actually getting some form of treatment because there's a lot of stress that goes with active surveillance. Like we have a paper coming out soon talking about how just the stress of coming into that appointment every 6 months or every year is astronomical because you'd wonder if this is the time they're going to tell me I got prostate cancer. Is this the time they're going to tell me I need to do something? This is the time they're going to tell me it's spread somewhere else. But usually we have a discussion about what your goals of care are and which one is the best one to get you there. If it's surgery or surgeons, we're happy to do it. But if it's radiation or chemotherapy, we're also happy to get you to the right people to do that therapy for you. So it's a point by point basis, not necessarily a strict timeline.
Any other questions? Throw them in the chat.
Go for it.
So a question for you, sir. Do we rely on PSA levels on a 6-month basis, or what would you recommend is the best way? And the other reason I ask that's because I have 3 uncles all with prostate cancer. So I feel like I'm at high risk, but I do my annual physical. What would you recommend above that?
Typically, it should be like a part of your annual physical with, your family care provider or your primary care provider, and then they use it based on the level. So most people who, I think every medical society outside of urologists, the cutoff is 4. So if your PSA is higher than 4, they usually recommend a referral to a urologist to then talk about, well, are you 4 and high risk? And that means that 4 is actually a really big deal for you. Or are you 4 and are there other markers we can look at to see if, are you a person who needs, like I mentioned in my talk or my part of the talk, an MRI, or maybe we, skip the MRI and you just go to biopsy. Some people do that as well. But it should be a part of your annual screening labs. And then based on that, if it's low, less than 4, they're just going to do it once a year, which is a totally fine thing to do. But if you are high risk, then typically we say you should get a little bit more close monitoring. So 6 months is okay.
Okay.
So you said there are currently no Black practitioners in Utah. Are there any recommendations of people who we could see?
Oh, I got a list for you. But yes, currently, as I mentioned in the chat, it's just me and Dr. Stephanie Washington. We are 2 Black residents at the University of Utah in urology, but as of right now, there are no board certified urologists in the state of Utah who have Black ancestry. But, if any provider, most of the providers here, are all great. I would recommend all of them to you. It just depends on what your question is and if you just want a general urologist, but if you want somebody who specializes in men's health, that's a different group. If you want, for female pelvic medicine, we've got a whole group that specializes in female pelvic surgery and female pelvic urology. So if you have a specific group, I can make recommendations. Otherwise, if you want a generalist, I can make recommendations for that too.
Is there a way I could contact you to ask for a specific recommendation?
Yeah, I'm happy. I can drop my email in the chat and you can feel free to shoot me.
Thanks, Doctor.
We're trying to recruit. Dr. Langston, any chance after you graduate, we might be able to hold on to you?
Yes, that is my goal. So, so as I said in the chat, if there is a job, if you got a job, I'll take it. And then I have one.
Territory. Pioneer.
We'll try to keep them. Just tell me who I need to talk to. I need to shake a few trees up at the university. Awesome. And we will eventually give us a few days, but we will have the this recording of this webinar and this presentation not only on our YouTube channel, so it can be shared with your family members, other men that you think are in need, or just, all I say from any of these webinars, if we can change the mind or intention or help you to advocate during your clinical appointments or someone in your family or loved one, and we make that difference where they're able to get that test, to get that screening done, or they make a lifestyle change, this is BPOU's mission. So this will be ready probably by Monday, definitely on our YouTube channel. We just do a little editing. Eventually we'll be on our website as well. And if you need Dr. Langston's contact is here, we can make that available as well on request for anyone who has specific urologic questions. Right. This is great. Well, thank you again, everyone. Any other questions before I shut her down?
Sure.
All right.
Would you hold
Everyone.
on?
Oh, is there a question?
Yeah, I have a question.
Yes, please.
Yeah, I just wanted to find out. I apologize, I got late onto the call. I just wanted to find out what's the view of the presenters, the doctors, on herbs as a part of the solution of the healing modalities.
As it relates to prostates and prostate cancer and sort of urology conditions, there are very few. Honestly, to be honest with you, there are zero that have enough research to allow us to safely recommend them to you as a part of treating whatever urologic condition you may have. So most often than not, we can't recommend them officially as a way of helping you with urologic needs.
Thank you.
All right. Well, thank you, everyone.